in primary, secondary, and tertiary prevention, but what there also is a new skill, and that is to be able to use data to assess how does each individual want to be engaged, to be able to use new scientific understandings of assessing that each of us are different in terms of our level of engagement with our own health, our level of willingness to be engaged, and the mechanisms through which we want to receive information. Think about the world that we now live in, public health professionals, and think of the opportunities that have been handed us that were never available to our predecessors. We now have not only these extraordinary data assets, but what you also have married to that is you have the extraordinary explosion in wireless and broadband technologies, which gives us this ubiquitous access to people through email, which gives us this ubiquitous profusion of smartphones with their texting capabilities, with their willingness and ability to connect us to our social networks which we are now learning are perhaps more important in shaping our behavior than the geographical communities in which we physically reside, especially as we deal with people of color and cultural issues. We have access to this mobile technology that allows us to have new mobile apps that are able to engage us on a variety of new and personally innovative and appropriate ways. We have the new revolution added to those things from sensor technologies. How many days, very few days go by for me when I do not have a heart rate monitor strapped to my chest, calculating my heart rate and feeding it to my Fitbit and putting it on the cloud so that I can track my own personal behavior. Sensor technology is now the single largest source of data in the world. And we have such a chance to take that. Then you take the proliferation in new gaming technologies, which will allow families to work out together having something called fun as opposed to a dose of exercise. Add to that the genomic revolution with this enormously personalized set of information that tells us not only about our genomic status, but also the relationship between our genetic structure and how it will interact with environmental toxins to proliferate and determine the course of disease. My point, ladies and gentlemen, is this. We have this wonderful moment where if we are smart and sharp and innovative and creative, we can take all of that and begin to know how people want to be engaged within the context of all of these new tools and shape, direct, target our intervention with them the way they want it, when they want it, how they want it. The challenge for us going forward is to understand much more granularly decision science. How do people think? We need to recruit now a whole new part of a whole new set of people to our team. Decision science team, adult learning people, people who get how do you help folk to actually use this to make right decisions. And then what will happen to add to that is that the people who are paying for health care, the employers, government for Medicaid and Medicare, those people are now changing the way they think about health benefit designs to begin to incentivize people to make more personally appropriate choices based upon the kinds of health benefits that they have. So adding the reaching out, the engagement, adding new tools to engage and teach and inform, to now adding to the last piece of that, new financial incentives that encourage people to begin to use those things in ways we've never had before. You have new tools that you have not had. And now we have to begin to work together to align all of those. And finally, and last, fourth point, we have to have the ability to recruit and coordinate the multidisciplinary health and medical care team that's necessary to solve problems across the continuum. We simply have to blow up the artificial silos between the public health system and the medical care system. I will tell you, I know you get it. I spend half of my time now trying to preach to the medical care side how valuable and important and reliable a partner you are. I'm extremely pleased that we've been sponsoring some very exciting work through the IOM, through the CDC, through HRSA, through ASTO, through the American Academy of Family Physicians and American College of Physicians, and a bunch of other partners who are really driving forward now this concept of integrated medicine and public health. We need to move that agenda forward, and we need to be able to, as I close out, to be able to say to a state Medicaid department who is really worried about how they're going to pay the bill in their state for ever-increasing Medicaid expenditures that are taking so much of the resources away from education and other discretionary resources. We've all got to get in there and find a way to make Medicaid work better. And so you've got the delivery system who's working hard, accountable care organizations, patient-centered medical home, delivery systems who have the responsibility for organizing the care of a population of people, organizing the care of a population of people. Make the delivery system as they focus on children with asthma, making sure that those kids get the inhalant they're supposed to get, that they manage the inhalant the way they're supposed to, that they're open in the evening so that the patient doesn't have to go to the emergency room and then get admitted, generating costs and costs and costs to the taxpayers of the state. They got to do all of that. But what they also have to be able to do is to say to the public health department, hey, public health is going to make available the workers or cause there to be workers to go out into the home and let's check on the mold and the mildew in the heating plant and the heating system and the air conditioning system and all those other allergens that are toxic that start to precipitate it. We will work together. Then we go to the governor. Then we go to the governor. And we say, because there is a partnership between us, public health deserves to have more resources, not less. More resources, not less. Here are the resources that we need, and we accept accountability for partnering with the delivery system, and the delivery system accepts accountability for partnering with the public health system. Together, we will decrease those emergency room visits for those kids with asthma. We will save the state a whole ton of money, much more than the employees cost. And above all, our babies will be safe. Ladies and gentlemen, this is the time for celebration of what you are. If you are willing to take this on, care continuum across the lifespan, then it says you're willing to do some business differently. That you're not willing to say, well, look, I just do what I do, and this is my little part of the world, and I don't know about those other people over there because this is my job. And we've always done it this way, like this always before, and I don't really want to change. What do I got to do? I'm the Medicaid person, but I got to worry about the Medicare department. We have to be uncomfortable with each other. We have to decide that maybe the patient is the most important, not the organization. We are so lucky. We're so lucky to have you, and I'm going to conclude with one thing I'm going to let you know, and you're going to see it. We're adding our voice. We're going to go on, as we release America's Health Rankings this year. America's Health Rankings is going to have as its fundamental purpose this year a celebration of public health workers. Y'all take care.
That was interesting.